Thank you, Mr. Chairman. Thank you for holding this hearing. I want to, like you, welcome our witnesses today. And I want to thank them for being here today to review the Defense Health Program. The pandemic has tested our military and its health system profoundly, and I would like to applaud the Defense Health Program's work and achievements during this extremely trying time. Our warfighters, I believe, are our greatest defense asset, and their readiness and capabilities depend on strong and sustainable military health care system. Our military's health system is responsible for providing care to 9.5 million service members and their beneficiaries who deserve the best quality of care that we can provide. In order to guarantee that standard, Mr. Chairman, we must ensure that the system is appropriately resourced, something this committee has prioritized. The military health system has undergone substantial transformation over the last several years, and I look forward to hearing about the challenges each of you have faced in this transition and how you've worked together to overcome them. In addition to providing health care, our military's health system also conducts medical research on a wide variety of topics such as cancer, infectious diseases, traumatic brain injury, and burn research, just to name a few. Funding for these important research efforts has grown from $210 million in 1992 to nearly $1.5 billion last year. That's a substantial investment, and I believe one that does not take into account the billions of dollars that we also provide annually to the National Institutes of Health to conduct research in many of the same areas. What's more, the President's budget request proposes to create the Advanced Research Projects Agency for Health at NIH. This new $6.5 billion federally funded research agency will focus on cancer research and other diseases such as diabetes and Alzheimer's. With all this seeming duplication of research dollars, I question at times whether DOD's medical research investments are truly focused on addressing our warfighters' health and readiness concerns, or simply investing in scarce defense resources in medical research that is also underway at NIH. So while we can all agree that this research is necessary, I hope our witnesses can provide a clear explanation regarding defense medical research dollars, what they're doing that NIH funding cannot or is not doing. In other words, is there duplication here, and if so, how do we get away from it? Thank you for holding this hearing, Mr. Chairman. Dr. Adirim and General Dingle, I'll direct the first questions to you, both of you. As I noted in my statement, this committee continues to invest in medical research without regard to other similar federal investments, it seems to me, at NIH. And maybe NIH is doing things you're doing better. I don't know that. Can you answer the question that I posed in my opening remarks, which is this: what specifically are defense medical research dollars doing that NIH funding cannot or is not doing? I think that's an important question.
Senator Shelby, I'll start with this question, and I think that's a very good question. We focus our research priorities within the department on the warfighter and on the needs of the joint force and on those conditions which may greatly impact our troops. We work very closely with the NIH and other agencies, coordinate very closely on research.
What do you mean by working closely? Is that collaborative working together on specific things? Name some of them.
Sure. So, for example, for something like suicide and mental health, there's collaborative research that we work with NINDS, have annual meetings on the research that comes out of both departments. And the work groups work together to ensure that the research that is being done and sponsored by each department or together, because sometimes these research proposals come out of both departments, are aligned to the requirements of our force.
Ma'am, I realize, and I think we all do, that the military has certain needs that the general population doesn't need, but the military at the same time probably needs all the needs and all the things that the general population, in addition to the military specific things. Is that a fair statement?
Sure, yes, sir.
So name your top 3 research areas that you're doing through the military research.
Sure, I'm going to turn it over to my colleague, General Dingle.
Okay? General?
Vice Chair Shelby, one of the things to tag on to what Dr. Adirim was saying, you know, the thing that the military also brings as it takes the National Defense Strategy, the DoD guidance, and our service guidances, the focus is on the survivability of the soldier. So prolonged
Absolutely.
field care, you know, in combat operations, trauma care, the latest technologies that we get from the civilian sector or in NIH, but taking those civilian technologies, medical technologies, it takes that military service research and development to incorporate it into tomorrow's battlefield on how it's going to be incorporated in a multi-domain environment. And I think that's one of the key things that we bring from the military as we couple with the civilian sector, academia, and the industry.
Okay. In the area that we all see a lot of, and that is improvised explosive devices, dealing with our military. That's a traumatic thing. We see it with our soldiers and everywhere. Is there any connection between our efforts to detect and prevent that and the treatment of the victims, our soldiers, after they've sustained huge blasts, you know?
Yes, sir. And that's one of the beauties of what the Chief of Staff of the Army set up with our Army Futures Command, because it takes that preventive mode and the detection to get ahead of that blast. But then even if that blast occurs, that's when the medical research development piece comes in, and we are studying those blast injuries and how to conserve and save lives. So the short answer, yes, we are doing those preventive measures. It's all being done under Army Futures Command, in which medical is incorporated across all of the cross-functional teams.
Is there any correlation in research dealing with, say, trauma medicine, emergency medicine, domestically, civilian, and what the soldiers, you know, the soldiers are shot at? They're shelled, they're step on mines, they do this. Now, they don't do, a lot of the civilians are shot at too much in the country. But I guess, is there treatment of wounds? Is there correlated research there, Doctor?
Yes, and I'm an emergency physician, and there's a number of research that has come out of the military that has greatly benefited the civilian sector. I mean, I can name the Roboa, which is a device that's used in trauma. There's fresh frozen plasma, which is currently being used for battlefield, which will have civilian applicability. So yes, you're exactly right. A lot of what we do within the Department of Defense, especially around trauma research, is applicable to the civilian sector.
In the area of warfighter, our soldiers, sailors, Marines, Air Force readiness and their health, is there research going on between the military research and the NIH research regarding with the health of our people, the health of our soldiers? Of course, the soldiers are probably, exposed to a lot different environments than the average American is.
Well, Senator, as you alluded to, there are multiple domains of research that we do in coordination and collaboration with the NIH, and a lot of which has applicability to the civilian sector and to the American people at large.
Okay. Admiral Gillingham, I want to shift to the ambulance ship, transport ship. The Navy recently issued a $235 million contract modification to construct a multi-purpose expeditionary fast transport ship. Can you talk about Navy medicine adapting to distributed maritime operations, and specifically how the expeditionary fast transport ship, an ambulance ship, will add value to those operations.
Yes, sir. Thank you for this opportunity. We're enormously excited about what is known as the EPF Flight 2, which is the vessel that was previously known as the Joint High-Speed Vessel. Designed initially as a logistics ship, in reviewing medical concept of operations for the distributed maritime operation and expeditionary advanced basing operations in support of the Marine Corps, recognized that we had a gap in the ability to respond quickly and much more quickly than we can with our Roll 3 platform, the TAH, or the hospital ship. So the ambulance ship, as envisioned, will allow us to respond to ships in distress, ships that may have been damaged in combat, be able to assist in personnel recovery.
Also gives you a lot of mobility on the water.
Yes, sir. The speed is it's a catamaran, bi-hull catamaran. Moves very quickly. It will allow an Osprey aircraft to land for medevac purposes. It will allow us, as envisioned and as being built and adapted with that additional funding, we'll have an operating room that will accommodate 2 operating room tables, a room for 18 ICU beds, a medical enhanced Roll 2 medical staff of about 100 personnel. So we see this as filling a critical gap in the DMO environment.
Would you say this, fairly say this is a high priority for naval medicine?
Yes, sir. It very much is.
Thank you. Thank you, Mr. Chairman.